So far this morning, I think the sessions have been instructive, fun, and everyone has been very polite. This session, I think, will be instructive, fun, but the gloves are coming off. So everybody knows this well-known acronym. Let's see if I can advance the slides, can I? No, that's not good. The what? That one. So as you know, it's actually women and girls who carry the gene for hemophilia A and hemophilia B. You all knew that, I'm sure. But the question of the debate is there a better term? There's a debate format. So we actually have 3 formal debates. We've invited and very graciously and courageously accepted, 2 nurses have accepted. So Nancy Hodgson and Betty Ann, they'll be the first debaters. Paula and Manuel will be the 2 physicians who are debating. And they'll each have 10 minutes. The acronym group, we're actually giving the last word to 2 women, 2 sisters actually, who are carriers of hemophilia B in this case, to find out what they think this should be called. And then we'll ask all 6 to come up and we'll have a bit of a free-for-all with all 6. And you know you have a very advanced voting system in front of you, so we will be asking you to use the high technology cards in front of you to give your opinions. That's when the crowd weighs in. There's actually a primary endpoint for this debate, and a summary of the conclusions of the debate will be submitted in a paper to a medical journal. So we actually take this quite seriously, and there's a very serious questions being asked by ISTH and other groups. So without further introduction, I'd like to ask Betty Ann and Nancy to sit at each end of the table, so they can't, we have to keep them at a distance from each other. And they'll have 2 minutes each to make their argument, 2 minutes to rebut the other argument, and 2 minutes to argue forcefully without any of my control.
Not the strongest.
And I will intervene if it gets nasty. So, did you decide who's first?
Pardon?
Betty Ann's first.
No, she decided that she was going to go.
No, she decided.
So I'll graciously give Nancy the opportunity to go first.
She's so sweet. So what would you call a woman or a girl who carries the gene for hemophilia? I've come up with 2 terminologies. A carrier with hemophilia, and in order to have that definition, I feel that they have to meet a few criteria. No bleeding issues or symptoms, a factor 8 or 9 level that is close to or in normal range. And the other definition I have is an individual who has mild or moderate hemophilia. And in order to qualify for that, they have to have bleeding issues or symptoms. They have to have factor levels in the 8 and 9 in a 5 to 40% range for the mild, or 1 to 5 for a moderate. And they also have to have a positive BAP score. And they need a decreased quality of life questionnaire, or that's due to bleeding. They don't have to have all those criteria, but they need to have a couple.
Very succinct. Betty Ann.
Thank you. Thank you very much for inviting me. I've waited for this for a long time. As opposed to Nancy, I have no criteria. So I went on a historical perspective. So when the hemophilia program was established in Sudbury, Ontario, Canada, in 1980, I was the nurse at that time, and I'm still the nurse there. We identified 58 hemophiliacs in Sudbury and northeastern Ontario. There were hemophiliacs, male of course, carriers, female, and the odd woman who had von Willebrand's disease. That has been the reality. So in 1992, I'll just give an idea of why it's the way it is. When Camp Wanakita accepted boys with hemophilia, they accepted the hemophilia, the HIV, and the HCV. Initially, there was funding available for siblings, and some girls attended. But they didn't attend because they were carriers. They attended because they were sisters. And then in 1997, the Canadian Hemophilia Society had a fundraising gig, and it was a beautiful calendar. And the calendar of children was beautiful. There were 18 pictures, black and white. 17 of them were boys. One was a girl. So there it is. We knew that daughters of men with hemophilia carried the hemophilia gene and focused on what could happen reproductively. But I'm not sure if we talked about menorrhagia. However, with women who were diagnosed with von Willebrand's disease, menorrhagia was a hot topic. In the past 10 years, things have changed. I'm set in my ways, old school, tunnel vision, or just old. So what is the right answer to the question? What should we call a woman or girl who carries the gene for hemophilia? A carrier, of course.
Okay, back to Nancy.
I want to bring to your attention from the World Federation of Hemophilia, age 5, at the very top, it says, any person, male or female, with 5 to 40% of normal amount of clotting factor has mild hemophilia. So why would we call her just a carrier?
Well, Nancy, you know that I've been the hemophilia nurse for 38 years.
You got me there.
So I should know. I'm not changing my mind.
The problem with that, though, is when a woman who has symptomatic bleeding, who's a carrier, has symptomatic bleeding, shows up to emergency department and says, I'm a carrier, what's your first thought? It's not treatment, it's not intervention, it's she's a carrier. So
Well,
then I worry, right?
Yeah, my first thought would be, first of all, I don't work in the emergency department. So I would say that it's somebody else's problem. Is our debate over?
You still have time.
I just worry that, yeah, when they come into emergency or even surgery, that if it just says carrier, that gets overlooked. Whereas you have mild hemophilia or moderate, that more attention will be paid. The referrals will be made to hematology. There'll be that stop before they cut kind of thing.
Well, that might be true.
Okay.
Sorry, you haven't convinced me yet.
I'm about halfway.
I really think the debate is over.
All right, the debate's over. So our next debaters, Manuel CARCAO and Paula James, they have a bit of a different approach. They wouldn't let us impose our format. They are doctors. They insisted on slides. So we have more slides here. And they have 4 minutes each to present their case. And then there's 2 minutes at the end for back and forth debate. So I will start the clock now.
4 minutes, eh? That's not a lot of time. Good morning or good afternoon now to all. So here's what we're debating, as you saw here, my conflicts of interest. So it struck me when I was preparing for this that here I am, a man, debating 5 women on what to call a woman. So should I even be here? Do I have any hope of winning this argument? And does a man ever have any hope of winning an argument with a woman? Every argument that we men have with our wives, with our daughters, certainly that I have, ultimately ends up with the same result. We either lose the argument and they don't talk to us for 1 or 2 days, or worse still, we win the argument and they don't talk to us for 3 or 4 days. So either way, we always lose. So in preparing for this, I thought I needed help. So I Googled how to win an argument with a woman. So this is what I found. So there's no way of winning an argument with a woman. So clearly I'm in trouble. So then I thought, okay, if I at least know the differences between how women think versus how men think, maybe I will have an advantage. So I looked at this, and these are some of the things. So I have never referred to anything as being carnation colored or fuchsia colored, so very different. Men and women are also very different with respect to grooming. I actually thought of David Lillicrap on this one. So we're also very different when it comes to going to a hairdresser. So this is typical for a man, and this is typical for a woman. It's when my wife comes home from a hairdresser and says, "Do you like my hair?" And did you cut it? I don't think so. And of course, we see ourselves quite differently, as you can see from That's my mirror at home. So after all of that, and looking Google, I'm no further ahead. So then I thought, okay, let's look at data, real data. So at Sick Kids, we follow boys with hemophilia, but we actually test their carrier mothers and their post-pubertal carrier sisters. So we actually have probably as many carriers as any other center in Canada. And when we do that, it's cutting off a bit. When we do that, we've been looking at factor VIII levels on our carriers, and this is what we found. So the number of carriers is at the bottom. It's actually 206 carriers, and you can see the distribution of factor levels. So the lowest factor level is 19% in a carrier. The highest is 200% in a carrier. They're all carriers. 77% of them have a factor VIII level of more than 50%, and 23% less than 50%. So the median was 68. But what you're seeing from that is there's tremendous, tremendous variability between carriers in their baseline factor VIII level. So for all other bleeding disorders, we distinguish between severe, moderate, and mild. We do that for hemophilia in men. We do that for other factor disorders. Why not for carriers? Why do we just simply refer to them all as carriers? We know from what Robert presented, this is a slide from his, that carriers can have severe hemophilia, they can have moderate hemophilia, they can have mild hemophilia. So should we refer to all carriers as simply being carriers? I think if, and kind of like what Nancy said, if we call all carriers simply carriers, we reduce the attention that should be paid to those with mild, moderate, or severe hemophilia. So this, I propose that we label carriers in the following way. We do call them carriers, but we differentiate. We call them carriers with severe hemophilia, carriers with moderate hemophilia, carriers with mild hemophilia, or symptomatic carriers or asymptomatic carriers. So they still have the definition carriers, but it's a little bit more qualified than just calling them all just carriers. And you saw something like this Other organizations feel the same way. The World Federation of Hemophilia stated this. This is almost a different version of what Nancy had to say. A woman who has less than 40% of the normal level of clotting factor is no different from a man with the same factor levels. She has hemophilia. Other organizations agree with that. And so to summarize the last slide, we should stop simply referring to all carriers as carriers. We should qualify them in terms of their severity. Thank you very much.
So that's hilarious. My hair looks exactly the same before and after I get a haircut. Okay, so here I am, standing in front of a statue of the most famous hemophilia carrier, Queen Victoria. And I'm willing to bet that most of you in the audience know exactly what I was thinking when this picture was taken.
It's gonna rain.
I wonder what Queen Victoria's periods were like. This is an important question and one that I have thought about a lot. In contrast, here's my opponent. I literally have no idea what he was thinking. That was a low blow. Sorry, Maddie. So what I'm going to be arguing today is for accuracy, not legitimacy, and not the term most acceptable to insurance companies or emergency room physicians or individuals with closed minds. I think the most accurate term is hemophilia carrier, and I think we should add symptomatic hemophilia carrier for those with abnormal bleeding. And if we take a look at what's been published on bleeding in carriers of hemophilia, there are many studies that have shown that carriers can have abnormal bleeding. And if you take the average, it's about 40% of hemophilia carriers who experience abnormal bleeding. However, if you look at the correlation between bleeding score and factor level, it's weak. The R-squared is negative 0.36. That means that only 36% of a high bleeding score can be explained by a low factor level. And so there are other contributing factors to bleeding in hemophilia carriers. If we look at this in more detail, there were 168 carriers included in this study, and of those, 65 had positive bleeding scores or abnormal bleeding. Of those, 27 had normal factor 8 or 9 levels. If we compare that to the 103 with normal bleeding scores, we see that 38 of those had low factor 8 or 9 levels. And so these two groups of patients require particular attention. And again, factor level does not completely predict bleeding in hemophilia carriers. My problem with the term mild hemophilia is that this is exclusively based on factor 8 or 9 level, and therefore in this form would only be applied to carriers with low levels. My problem with that is it ignores carriers who bleed with normal levels, and it unnecessarily labels those with low factor levels who don't bleed. Furthermore, the pattern of bleeding is very different between these two groups. So males with mild hemophilia tend to experience more musculoskeletal bleeding, while carriers tend to experience more mucocutaneous bleeding. And so to this point, I've been focusing on phenotype, bleeding score, and factor level. However, genotype is very important as well, and I think the genetics of this condition have to be taken into account. And that brings us to a very undeniable fact. And thank God for that. So I do not think we should have to adopt an inaccurate male term to legitimize carrier bleeding. Rather, I think we need to open our minds and learn more about this important problem. That includes improving our understanding of why it's happening in the first place and accepting the validity of an accurate female term that reflects the undeniable genetics and the reality of abnormal bleeding experienced by many of these women. And I argue that that term is hemophilia carrier with symptomatic added for those with abnormal bleeding. Thank you.
So they have both run over their time, as they tend to do. So I'll ask them to sit back down and come back later. And so we have our last two debaters, Emily and ERIN van Deusen, two sisters. And I'll let them introduce themselves because I'm sure they have lots to say. And we'll give them the final word in terms of the debate. So again, you can sit at either end of the table, far enough away from each other. Go.
Age before beauty. I'll introduce myself first. My name is EMILEIGH van Deusen, and I am a person living with hemophilia B factor 9 deficiency. I am a mental health and addiction social worker in Nova Scotia. Me and my sister are both from Nova Scotia. Is it okay if I just jump right into my argument? Perfect. So I believe what we call women with the gene for hemophilia has implications that extend far beyond simply labeling or attaching a diagnosis to a woman. What we decide to call women with hemophilia as healthcare professionals and as a society will ultimately determine the course and quality of treatment women receive when accessing care for their bleeding disorders. The term, to me, symptomatic carrier, for myself as well as many other women, portrays an inaccurate depiction of the extent of our bleeding disorder and problems. I feel as though this term minimizes our bleeding symptoms and can be interpreted as though we are just carriers of the gene of hemophilia, instead of women living with and experiencing problematic and harmful bleeding. I introduce myself to all of you today in a purposeful way to demonstrate that regardless of my biological sex, I'm still a person living with mild hemophilia B. My whole life I've been labeled a symptomatic carrier due to having low factor 9 levels of around 34%. On numerous occasions, I have received inadequate and poor treatment regarding my bleeding disorder based on this label of just being a carrier or a symptomatic carrier. And I should note that I do have a really good HTC team at home, and it has never been improper care with them, but throughout other medical professionals who wouldn't be as familiar with hemophilia. And I feel as though if my sex were male and I disclosed that I live with mild hemophilia B, my treatment would have been impacted significantly and taken more seriously even, and I would have received a better standard of care. And as we know in Canada, many healthcare organizations, such as the Nova Scotia Health Authority, have a commitment to health equity, meaning that it's committed to reducing health inequalities experienced by patients and implies that a person's health should not be compromised or disadvantaged because of an individual or population group's race, ethnicity, gender, income, sexual orientation, or other social condition. However, based on my own lived experiences, I know the statement to be incongruent with treatment I've received based on my diagnosis of hemophilia and my sex being that I am female. The traditional and historical belief of males with a gene for hemophilia being the only people to experience bleeding issues and concerns, I feel is outdated and creates inequity in healthcare treatment for women who also have the gene and experience abnormal bleeding. It causes us to face barriers when accessing healthcare outside of our own hemophilia professionals. Hi everyone, my name is ERIN van Deusen and I am a carrier of hemophilia B. I feel like I have to give a little bit of a disclosure myself because unlike my sister, I am sort of going through a bit of an identity crisis with my own bleeding disorder. So it was really challenging for me to try to stick to my stance of we are carriers or symptomatic carriers. I think it is important for carriers of hemophilia to have some say in the way that we are defining our status. I also think it's imperative to have congruent medical terminology and defined standards of care to ensure equity in treatment. I don't believe that girls and women who carry the hemophilia gene should be automatically labeled
as hemophiliacs, as I believe there are some really important conditions to consider before labeling. I do believe girls and women who carry the hemophilia gene with normal factor levels and don't experience any abnormal bleeding should be called carriers of hemophilia. I think carriers with normal factor levels but who are experiencing abnormal bleeding could be called symptomatic carriers. But the thing is, I sort of agree that if a carrier has low factor levels and experiences bleeding symptoms, that she could be called a mild hemophiliac, or maybe a carrier of hemophilia or a carrier of mild hemophilia. And I'm sorry to say it, but I just can't get on board with the term hemophiliac. I don't feel comfortable labeling myself as a mild hemophiliac for a number of reasons. Firstly, I'm uncomfortable with this label because I haven't had a medical professional confirm this, and I don't feel confident in my medical knowledge or my ability to self-diagnose. Secondly, I am conflicted with the varying ranges that are considered to be mild hemophilia. I have read in literature that mild hemophilia is defined by factor levels between 5% to 35%, also 5% to 40%, and then again 5% to 50%. I'm worried about being labeled a hemophiliac and encountering barriers such as life and disability insurance. I think the discussion around labeling is personal, and there are many pros and cons to be weighed when considering how we want to be medically labeled.
I was going to quote a stat from this, but we've heard it multiple times on folks who are kind of more on my side, which is great. So as you know, the WFH considers a woman between 5 and 40% of the normal amount of factor to be considered to have mild hemophilia, and that would be true for myself, considering my factor levels around 34. And the booklet describes how even women living with 40 to 60% of factor can experience abnormal bleeding as well, and then to Erin's point, those women would be called symptomatic carriers. But I'm left wondering how we made this distinction about labeling women symptomatic carriers. What would we call a male who has 50 to 60% normal clotting factor? Is he a symptomatic hemophiliac? Is he a carrier of hemophilia? Or is he just simply have mild hemophilia? More importantly, I am left concerned about the fact that even though women can experience abnormal bleeding symptoms, the exact same as those seen in men, as well as the added symptoms of menstruation and postpartum bleeding, that their treatment is often defined by their carrier status instead of their factor levels. I myself have been told, you are a symptomatic carrier. Your factor levels are low for a carrier. It is my belief that labels such as these that have been placed on me by medical professionals have the ability to affect my health care and treatment. I feel this way because I've experienced it firsthand. Times that I've experienced the powers of this label are when a doctor told me I didn't need an infusion before having a mole removed because I'm just a carrier. When dental professionals advised me it would be fine for them to cut out pieces of my gum without an infusion because it was just a minor procedure. When hygienists ignore my concerns and cause my mouth to bleed for days after cleaning. And 3 years ago, when I broke my wrist and was told I would not be infused that evening and had to come back the next day because the hematologist on call had reviewed my file and didn't deem it necessary for me to receive an infusion of factor 9 that evening. I still live with wrist pain to this day. I've never had a chance to explain to anybody about that label, symptomatic carrier, that's placed on my health record, and I feel that it truly doesn't explain my bleeding symptoms. I repeatedly asked to be infused that night when I had broken my wrist with factor 9, and I was repeatedly told no. I believe that a file and a label and the cognitive bias and belief that it is really only men who experience serious bleeding symptoms is what defined my treatment that night. The truly sad part about all of these experiences I have shared with you is that these are some of the more mild experiences of mistreatment. I've heard from other women with hemophilia about how their lives have literally been in jeopardy due to improper care and the pain and suffering that they have endured and continue to live with due to not receiving the correct treatment for bleeding disorders because they are perceived as just carriers.
I think there are circumstances where the benefits of being labeled as a bleeder or hemophiliac will increase your ability to access appropriate care. But I also think for some people, such as myself, with less severe bleeding issues, that labeling could be more harmful than helpful. I like to be on the safe side, so I do carry my Factor First card in my wallet, and I've been considering ordering a medical alert bracelet. After having conversations with my friends and colleagues, and they brought up the question, well, what would happen if you were in an accident or you were unconscious and they didn't check your wallet, they didn't see this Factor First card? I think that, again, the lack of consistent definition for a person, regardless of their sex, to be considered a mild hemophiliac makes it more difficult for my own identification as a person with a bleeding disorder. The information booklet on mild hemophilia states that mild hemophilia can be very serious and even life-threatening if injuries or bleeds are not treated promptly and adequately. The danger is that a person with mild hemophilia, having so few bleeds, will not recognize one when it occurs and will not know what to do. Something that also stood out to me while reading the WFH document regarding symptomatic carriers is most carriers will be asymptomatic in day-to-day life activities. However, if subjected to trauma or medical intervention, they may show prolonged bleeding. In these instances, carriers must be treated in the same way as patients with hemophilia. I've taken some time to also read through the insurance documents provided on the CHS website because I'm currently shopping for life insurance for myself and my partner. I was concerned to read that deliberately concealing information could void your policy even if your claim has nothing to do with the undisclosed information. But what if I didn't deliberately conceal my information, but I failed to identify my condition properly due to a lack of congruency in medical terminology, disagreement amongst medical professionals, and my own identity struggle? This is such an important topic of conversation because it could have really serious implications. I'm grateful for the current and future research on women on bleeding disorders because I think we're moving in the right direction.
They have 1 minute to conclude, each.
If I had to say the one thing about living with hemophilia that terrifies me the most, it isn't the bleeding symptoms and the problems itself. I know with proper care and treatment, my bleeding symptoms can be managed. What scares me the most is the fact that I know when I'm in trouble or need medical attention, it is up to a health professional for them to use their own clinical judgment and power about my bleeding disorder, that they are able to deem a priority or not to provide me with treatment. I'm left with a sense of powerlessness. But it is not the doctor who has to live with the consequences of these decisions. It is me. It's my fiance and it's my family. We're the ones who live with the pain and suffer the impacts of these decisions. This needs to change. Women's voices and stories need to be heard, and they need to be taken seriously. As a society dedicated to improving the lives of people living with bleeding disorders, we need to stand up and speak out to better the quality of care that our sisters receive. So thank you for giving me the opportunity to speak today. And to answer the question, what do we call a woman with the gene for hemophilia? I would recommend asking the woman herself first, maybe. But it's my opinion to call them women living with hemophilia. But I can really only truly speak for myself. So in case you've forgotten already, my name's EMILEIGH Van Deusen, and I live with mild hemophilia factor 9 deficiency.
So as I said, it was a challenge for me to really stick to my stance because of my own struggle. But I did try, David, I promise. I do agree with my sister's desire and quest for the equitable treatment and recognition of her disorder. And I really would just like to stress the point that there is a need for medical professionals to get on the same page, and it will make treatment easier to access for women with or carrying inherited bleeding disorders.
Yep. Nancy, Betty Ann. Now you have to face the music. So perhaps we should get the crowd to weigh in right away. And you've heard a whole bunch of different. You've heard Manuel's definition of severe, moderate, mild. Above 40%, but symptomatic. Above 40% asymptomatic. You've heard ERIN's call for congruency in the definitions. Emily was very clear about to be called a woman living with hemophilia or having hemophilia B. Would people want to come up to the mic and say what really struck you in terms of the best definitions, the best terms that you've heard? And get your cards ready. So green is I agree, red is I disagree, and yellow is I'm really confused, I'm not sure. Okay?
Well, I didn't bring up any cards. First of all, I want to congratulate all the debaters. I found myself agreeing with everyone, which doesn't make this any easier. But, you know, there are three things you can look at when you want to designate someone as having a disease. You can look at the genotype, you can look at the clinical pattern, you can look at the laboratory results. When we're diagnosing a man, we ignore the clinical phenotype. You diagnose hemophilia based on a causative mutation and a factor VIII level, period, or 9 level, period. So if we're going to be consistent, we would use the exact same definition for a woman. However, based on some of the things I heard from Emily and others, particularly around diagnostic confusion and clinical care that they might receive, I think we should be a little more expansive when we're looking at women and a little more perhaps directive. And I think that we really should look at the clinical bleeding pattern to avoid undertreatment or medical confusion. So I think we really should use the bleeding pattern and use the term hemophilia to avoid clinical mistreatment. So I'm kind of, I don't know what color card that would give me.
Hold up your cards. What do you think about Jerry's?
I got some support.
You got some greens there. There's one red, some yellow. Okay, a lot of green there. Michelle?
I also want to congratulate you all. I think you did an unbelievable job, and especially the Van Deusen sisters. I thought what was really remarkable was the two of you were both emphasizing the need for the patient herself to decide, and there are important ramifications with regards to whatever label we apply. I wanted to address some of the statements that EMILEIGH was saying. I think that we can all agree that the term carrier sort of inherently means that the individual is unaffected by whatever disorder, genetic disorder that they are carrying, but that there is a risk that they could transmit that gene and that their offspring could be affected. I do think that men with hemophilia, whether mild or severe, are often mistreated or improperly or inadequately treated even when they present to the emergency room. But I can only imagine the additional hurdle of having the term carrier, because in every other domain of medicine, the term carrier just means you carry it and nothing else. So I'm not totally sure, because I think the problem is that the term carrier, to Paula's point, is sort of culturally embedded in the way that we speak about your mild hemophilia. And so all of us apply the term automatically, whether we're writing it in a chart or not. That's all what we're all thinking. So we have to figure out what I think is going to be culturally acceptable to the patient, but also to medical professionals. I think one thing that is really interesting and it keeps coming into my mind is that, and I think Rob Sidonio was showing it in his slide when he talked about he was comparing the bleeding between patients with VWD and carriers, and he talked about the mucocutaneous bleeding and et cetera. And even when we think about the bleeding, and Manny was mentioning it with, men with hemophilia versus carriers, and that there's more, musculoskeletal bleeding, et cetera, in men. I think we don't really know the answer about whether or not men would experience more mucocutaneous bleeding and whether men with mild hemophilia would experience more mucocutaneous bleeding, because they don't bleed monthly from their genitalia and they don't give birth. But I don't think
that was awesome, and I agree with Jerry that I was really on both sides of this debate. I thought you guys all made great points. I guess my question or comment would be, so we have 2 girls in our clinic who have severe hemophilia who are not technically carriers, and they get joint bleeds and muscle bleeds. And how would you differentiate, or do you need to differentiate girls that have severe hemophilia from carriers who have severe levels?
I mean, men are carriers too, huh? Men with hemophilia are carriers. And I imagine some over 40% probably have some bleeding symptoms, probably something else we don't know. John?
What about the term heterozygous for hemophilia?
Oh. Okay, cards, please. Heterozygous.
Very popular.
Cards. Not, people are, there's some reds there. Yeah.
I think that using the term carrier is a chauvinist nomenclature. You know, it defines a woman as being responsible for an offspring that is a cripple or has a disorder. So, I mean, why don't we simply call a person who has a bleeding disorder a person who has a bleeding disorder? Forget about the fact that she is or she is not going or likely to give birth to a boy with a problem.
So your position is whether it's men or women, we forget the carrier issue because they're both they could both be carriers, and just call people a person with a bleeding disorder. It could be mild, it could be moderate, it could be severe. If they're beyond the mild level, they could be asymptomatic or symptomatic, both.
Oh, David.
Okay, over to Mary Frances.
Thank you. This is all wonderful. I kind of like George's idea of the person with the bleeding disorder, and I also, coming from Newfoundland, where we have a large population with mild hemophilia, I would say that actually, in many situations, mild hemophilia is a very serious disorder, and people have very serious outcomes. So I actually very much dislike the word mild at all, because it's all within context. You know, a person with mild hemophilia with the wrong treatment, many of them have died and do die, and experience all sorts of dreadful outcomes. So I mean, one term has been, which I don't think will exactly work either, but it's episodic hemophilia or occult hemophilia or something like that. But I think the term some sort of a person with a bleeding disorder is more helpful, because it all depends on the context. And if you have a mild bleeding disorder, but in certain situations it can be life-threatening, it can be limb-threatening, it can be disastrous, and that's really what we want to avoid. So I'm not very fond of the mild, moderate thing.
That's really
something else.
That's really not very helpful to our debate. You know, it's getting
Thank you.
coming to a consensus anyway.
David, can I just make a
Rochelle.
quick comment before we go to
Yes.
the next question?
Episodic bleeder.
Something that I've tried when trying to advocate for care, whether in the emergency room or whatever, and is to let folks know I have a bleeding disorder. That's what I say. I don't say I'm a symptomatic carrier. I don't say I'm a carrier. I don't say I have mild hemophilia. The first thing I say, almost as a social experiment, because I'm a social worker, is I have a bleeding disorder. Oh, interesting. What kind? And then I say I have hemophilia B. And the exact words I've heard is, so you're a carrier. Dot. End of conversation. And then I'm fighting my way back to the starting point and explaining myself all over again.
So you would agree with Dr. Rivard's suggestion that we get rid of the term carrier in terms of talking about clinical issues?
I actually think the same. I think that we need to abolish the term in terms of nomenclature, but perhaps use it in a genetic counseling context. But in the clinical setting, I think that the word carrier, if you hear it, what we're saying is silent carrier, is what we're all saying. And you know, if you think of somebody with G6PD, what does the woman call herself? She either has G6PD and she's symptomatic and she's hemolyzing, or she's not, and we discuss it based on phenotype. We don't call her a carrier of G6PD clinically. So at least I don't. But just to finish, so I think that the word carrier is implicitly saying silent, and I think that it needs to be changed into a person with a bleeding disorder. I have hemophilia, I have a mild case, or I have a severe case of hemophilia. Whether you're a man or a woman would be my opinion.
Can I just make one very short comment? Certainly I agree. If you have a factor level that's very, very low, they should be called severe hemophilia, moderate hemophilia, or mild hemophilia. But if you're a carrier, if a person is a carrier and they have a factor level of 150%, which they can have, they shouldn't be told that you're normal, because if they forget the fact that they're a carrier, it will potentially have implications in the future. So I think you need to have a nomenclature that covers all possibilities. You can't just sort of say you have a bleeding disorder. 200% is not a bleeding disorder. If it was a male, you would say he's normal. So
Well,
I
I think that's a good point. So in the gray zone, you might need to think of another terminology. Whether it should be carrier or not, I don't know.
Okay, well, we have got, this is a hot topic, I can see. So,
Yes.
Dr. James.
Yes, so-
We've got 7 more minutes. So.
I won't take that long. So, being someone who has turned to the medical literature to try to learn more about this conversation, this topic, I can't find anything when I go with traditional search terms using female or woman and hemophilia and get anything about what we understand are the unique needs of hemophilia carriers. So without plugging in the word carrier, I lose everything written on this topic in the past. So I pray that for the sake of continuity and in order to build on our foundation, that we think of some terminology that preserves what we do know already and not lose it by diluting it in our terminology.
Okay, we could be here for 3 hours, you realize. So I wanted to congratulate everyone. I thought actually having the various groups look at this in different ways was a real plus, and I really liked everyone's contributions. And I hear Emileigh's frustration with what happens with her medical care. And I think part of that is because this is complicated. I mean, that's why people are queuing up here. Because I think no one really has the right answer, because it would be so much easier for you and for us. So just quickly, a few words. So the genes for hemophilia are on the X chromosome, and I say that because if I hold up these cards, I can't see a difference. Because, and so I just use that as another genetic disease because I have color blindness, and so anyway, that has relevance of nothing. But when Manny shows, what colors you wear, you go to my closet, I have blue colors because I can see blue. Sorry, that's ridiculous. So I think, actually, everyone sort of nailed this in different ways to me. I mean, I actually would keep the term carrier because I think of what Andy's just said, that this is really, it's ingrained in our history. And I think people do understand this. So if you have a normal level of factor, if you're female, you have a normal level, and you don't have bleeding, they carry a genetic disease, a genetic disorder. And I think that's important for them to realize that and for the community to understand that, because most medical professionals get that. I think if you carry the condition and you're symptomatic, I actually like that term, and your levels are normal, you're a symptomatic carrier. And I think that's it, because we don't really understand that. I mean, Paula and I discuss this a lot, and I'm interested to hear what Robert says, but so I think a hemophilia carrier who is symptomatic, I think we are beginning to understand what that means. And then I think for Emileigh, she's a hemophilia carrier with mild, moderate, or severe factor deficiency. So whatever. So for her, she has hemophilia B. So a hemophilia B carrier with whatever the number is of where her factor levels are. And I'm actually sort of parroting what Manuel showed here, and Paula showed. So I think that those, for me, would help understand management. And you've got the genetic component, and you've got the phenotype component.
So can we have a vote on those 5 terms? So it's severe, moderate, and mild hemophilia for a woman, plus when you're beyond that range, a symptomatic carrier, and when you're beyond that range with no symptoms, you're simply a carrier without symptoms. What do people think of those 5 definitions? So we've got more green, quite a bit of yellow, and some red. So we're not there yet. Pam.
Hi. I will start by saying that I'm an old mom and an old carrier, and also that I didn't know I was a carrier until I gave birth to a son who has hemophilia. I wish my mom knew then what we know now. It's a different issue, but in the same way as I'm standing here thinking about that, I try to be articulate. I try to express what's going on. Over and over again, when I'm in a different clinic, orthopedics in particular, dentistry, different realms where I'm outside of my hematology clinic, that's ignored again when I say I'm a carrier. I hear what you're saying about the insurance, and yeah, when you want to go and get mortgage insurance or disability insurance, you're thinking about that. But honestly, if it's a difference between someone taking action, if I'm in a serious car accident that could potentially save my life, and paying the extra insurance or even being denied insurance, I still feel the same way, that what does symptomatic carrier mean to that person who potentially is going to save my life in the emergency room? I know that's dramatic. I know we talked about that this morning, Bernadette, but at the same time, that's reality. People don't have a clue how to respond to me when I tell them that.
I don't think that's dramatic at all. I worry about that every day on the drive to work, right? I have a Factor First card, and in the instances I've given it to somebody outside of my HTC, I may as well give them my Air Miles card, because the way that they look at it, it is not helpful. I feel that, Pam.
Okay, last intervention, Dr. Sidonio.
So, I feel reluctant to come up here and agree with only the two men, David and Manny, on this issue, but I agree that, and so there's 2 points. So in the US, if you go to an emergency room, like Emily sort of mentioned, and you say that you're a hemophilia carrier and you leave no other designation, there's a specific code for a genetic designation. You cannot get any sort of therapies, nothing's associated with that. And so it really needs a medical code outside of a genetic designation. And so I know this is not all about the US, but I think that's important, at least for us, and it's difficult. And I agree also about taking the term back, symptomatic carrier. It's been used as a derogatory term, unfortunately, but I think it's an appropriate term for a carrier that has normal levels, that still has some bleeding tendency, because there needs to be some designation. I don't think it should be a blanket statement. I don't think it should be used on you. And so I would agree with the decision about moving forward with saying that we should at least maintain the carrier status, and then we should also refer to it in the deficiency. So, you know, for you would be a hemophilia B carrier with mild factor IX deficiency. I know that's a really long term, but I think it sort of conveys exactly what's going on. And I think, you know, just general education about the genetics I think is important, because I think when you say carrier, I think it's very confusing for a lot of physicians. And I just think it's a little bit difficult. So I would agree with that. And I think this is timely, as Rochelle knows. I put in a proposal to ISTH to address this exact issue, because I was very frustrated. I heard a lot of cases like Emily, you're not alone. I've heard hundreds of those cases. I get emails all the time with the exact same story. I got an email 2 days ago with almost identical story. And so I think this is where we can get together with ISTH and we propose, you know, addressing this nomenclature, and Rochelle's going to be involved in this, and there'll be some people in Europe as well. And so hopefully over the next year, we'll come up with some system, and then we'll come to each organization, particularly the patient advocacy organizations, and see if that's something that everybody would generally agree with. And hopefully that will improve the communication. But I can tell you, when we just did a literature search with a librarian, it's very difficult to find all those articles because they're labeled so many different ways. But I think improving that communication is going to be the key to moving forward and having people not feel the way you feel like when you come to the emergency room. So I think this is very timely, and I think this is very helpful for me at least. And hopefully over the next few months, we should have a meeting at ISTH and discuss these issues, and I'll take what we consider as the Canadian opinion. So hopefully you guys will give me a somewhat unified opinion, or at least a majority of what the opinion is, so I can take it back as the Canadian opinion. So,
yeah, we'll definitely put together a paper with some of the ideas that have been presented. Okay, George, I can't deny you.
I just want to try once more, but I don't see the point of keeping the word carrier, because this will be useful only once in your life when you go to the genetic counselor, which at that time will be very useful to know and point out that you're a hemophilia carrier. But if your factor VIII level is 200%, why would you be, what use would it be for you to be called a carrier on the street, in emergency room, wherever, when you're looking for a job? why you need to be called hemophilia carrier with your factor level of 200%?
Okay, so I think these guys have done a fantastic job. I really think you should give them a great hand. It was hard.